Fighting Blindness Canada's Viewpoint is an education series that brings you the latest in vision research presented by health experts from across Canada. The session you're about to watch is a recording. To learn more about the research we fund and upcoming programs and events, please visit our website at fightingblindness.ca. Viewpoint is proudly presented by Bayer and supported by Abbvie, Apellis, Astellas, Beacon Therapeutics, Biogen, Johnson & Johnson, Novartis, and Roche. Thank you for watching. We hope you enjoy this session and share your thoughts with us in the comment section below.
So the main format of this is going to be a conversation with you and Dr. Parnian Arjmand, who's been so nice to join us here on a Saturday. So I'm going to start off with a quick question and then really turn it over to the audience to ask the questions you want. And we will have, I think, do we have another mic here? We're going to try to find another mic, otherwise I'll come around with the mic. But just to give a quick background, here we go. I want to give a quick introduction to Dr. Arjmand. She is a vitreoretinal surgeon who specializes in treating medical and surgical retinal conditions like age-related macular degeneration. She is a native of Toronto, and she completed her undergraduate and graduate studies at the University of Toronto in an immunology specialist program before going on to medical school at McMaster University and an ophthalmology residency at the University of Ottawa. She's also completed fellowships at the University of Toronto, where she served as the chief fellow. And she currently works at the Mississauga Retina Institute, the Burlington Laser Eye Center, and Baycrest Health Sciences Center. So welcome.
Thank you so much. It's such an honor to be here today, and I'm really excited to interact with each and every one of you. And so, yes, please feel free to, be candid and ask your questions, anything about macular degeneration and retinal disease.
Perfect. So just to level set, if you can give us a really quick sort of description of what AMD is, so we're all on the same page, and then over to you guys.
Absolutely. Thanks for that question. So, AMD, which stands for age-related macular degeneration, is an age-related condition that happens to a large number of Canadians every year. It's extremely prevalent in patients over the age of 70, especially amongst patients who have more fair skin, Caucasian, blue eyes. Those tend to be certain risk factors, for example. This is a condition that starts as a stage called dry AMD. So that's the earlier stages of the disease. And dry AMD doesn't necessarily require treatment. Even dry AMD is staged as early, intermediate, severe to advanced. And then in some patients, that dry AMD progresses to a stage called wet AMD. So you might hear, your friends or your neighbors, yourself, for example, being told that you have some fluid or bleeding in the back of the eye. And that refers to wet AMD. And that's a condition that leads to rapid loss of vision unless it is treated, and thankfully we do have treatments now for wet AMD. And so, when you say you have AMD, it really matters what type of AMD, what stage of AMD, to determine what degree of vision loss and what type of treatments are necessary for it. Yeah.
There were already some hands up before.
Yes, absolutely. So go ahead.
Hello.
Thank you.
Yes. Oh, okay, great.
Hi. My question is in regard, two questions. One of them is in regard to if I'm getting injections nowadays every 4 to 6 weeks, is it okay to do cataract surgery? And the second question is, I read actually from Fighting Blindness and so on that now they're working on new improved drugs, which you don't have to get them so frequently anymore. What stage is it now?
Thank you for asking that question. So yes, cataract surgery is definitely possible, and it's totally okay to do it while you're getting your injections. Cataract surgery deals with the front of your eye, which is the crystalline lens in your eye. It gets replaced with a permanent lens and replaces it. And that is totally unrelated to your injections. Many of my patients have cataract surgery even a week before their next injection is due. So that's totally fine. That's totally safe. So your second question about drugs, yes, you're right. we're very lucky. We have a lot of medications now available for injections for patients who have wet AMD. It started off with Avastin, but now anyone who's over the age of 65, who's Canadian, who has OHIP coverage, often gets either a drug called Lucentis, Eylea, or Vabysmo. Those are the 3 common medications that we have available. You might have heard about Vabysmo, which is also known as faricimab. That's the latest drug that just got approved in Canada in August of last year, in 2023. And the promise of Vabysmo is that it lasts longer than the older drugs that came before it. But the thing is, there is no guarantee. So there are clinical trials that have been done that have shown that Vabysmo lasts longer than the other drugs, but that's not a guarantee. So personally, I have a lot of patients that I've switched. I switched a ton of my patients to Vabysmo from the older drugs. Those who were getting injections every 6 weeks, I switched them, but they didn't necessarily, not everyone was able to go beyond 6 weeks. Majority did, but many people didn't. But that's a good question to ask your retina specialist to see if they think you can be switched to a newer drug. Yeah.
I have a cynical question in regard to this. Why a clinic, for example, clinic I'm going to, would have the incentive to give you another drug which lasts much longer? They're losing business in that case.
You know, that's funny, but retina specialists, especially in Toronto and in Canada, we're very overwhelmed with the population of patients. We have more injection patients than we ever thought we would. We can't even care for other types of diagnoses or surgeries that we want to do because there's so many injection patients. So we are more than happy for our patients to come and see us less frequently. And there are definitely many incentives for us to prolong you to longer so that I can see the other patients who have other diseases that requires my attention. Yeah. I'll just let Jackie tell.
Hello. I had wet macular degeneration in my left eye, and I had 26 Lucentis injections. It has dried up, and actually the only issue I have is the central part. The peripheral vision is blurry, but it's not really bad. However, my right eye, which was my dominant eye, I never had wet macular degeneration. It was dry. But the dry macula the dryness is going over top of my macula and causing it's hard to explain. It's like a foggy sort of a misty, and affects my vision quite a bit. Can't drive anymore, of course, but and I think you mentioned the last injection. What was the latest one?
Vabysmo.
Yeah, that's right. I think my ophthalmologist has me on that. But he did mention in the States that there's another one that's better, and yet is there any possibility that will come to Canada? He didn't tell me the name, but you might know of it.
Yes.
If that would come to Canada soon. And another thing I just want to ask quickly, Vitalux. Lots of people that have macular degeneration are on Vitalux. My ophthalmologist told me that it only helps 15% of the population. Would you recommend staying on Vitalux? Because I have stopped taking it, and I wonder if I should go back.
Those are all very good questions. So I will address your question in multiple segments because I think you asked about a few things. So you said my central vision is gone, my peripheral vision is still there, and that is in keeping with macular degeneration or AMD. Macula is the anatomical center of your retina. Your 20/20 vision comes from your macula, but your peripheral vision comes from outside of your macula. And that's why when we have AMD, unfortunately, even despite injections, we lose our central vision to some degree, and that explains why your peripheral vision is preserved. Now, as I mentioned to you at the beginning of this talk, AMD has different stages. If you have dry AMD, that doesn't have any treatment right now in Canada, as you alluded to that. It sounds like you have dry AMD in your other eye. And when it progresses to atrophy, which is something that can happen, atrophy is cell loss. When unfortunately some of the cells, they shrink, they shrivel, and they stop functioning, and that's called geographic atrophy. Yes, there is a drug that's approved for geographic atrophy in the US. It's called pegcetacoplan. Unfortunately, it's effect is really just to prevent geographic atrophy from getting bigger. It doesn't reverse the disease. It doesn't improve your vision. It only minimally or marginally reduces the chances of it getting worse. And you have to get an injection in your eye every month forever for it to have any type of benefit. That benefit is so small, and the side effect profile, recently there's been some side effects that have been reported from the US from that drug that make us a little bit skeptical of this drug ever getting approved in Canada, because the risks may be higher than any type of benefit it may provide. However, the future's bright. There are treatments in the pipeline for atrophy. There's light therapy that might get approved by the FDA and later in Canada in the next 2 to 5 years. That's promising. It's by a company called Lumera, but that's not yet around. And then there's other injections like pegcetacoplan that are being in clinical trials right now, but nothing that's been approved yet. Oh yes, and a question about Vitalox. So you probably have a lot of, yes, so Vitalox is just a company name. There's other companies, Preservision you might come across, and other companies that make this formula. The formula is called AREDS 2. So AREDS is the AMD eye disease study. Basically, it's a large study that was funded by the NIH in the US. It's highly evidence-based. It's the highest level of evidence we have to know what we can do to prevent the progression of dry AMD. And it has 6 components in it. It has lutein, zeaxanthin, zinc, copper, vitamin C, and vitamin E. And these components have been shown together to significantly reduce the risk of progression of dry AMD to wet AMD. So if you already have wet AMD, you don't need to take that because you already have wet AMD. But if you have dry AMD in your other eye, you can keep taking that medication, the Vitalox or AREDS 2, because you want to protect your other eye that doesn't have wet AMD yet from developing wet AMD. But the effect is marginal. It's only like reduction by about 15%, like you said, per year. So your risk of progressing to wet AMD is only reduced by 15%. So it's not a magic cure. It's just something you can do.
Those vitamins that you mentioned, I take them separately, like individually, not in the tablet.
Yes, they're all combined in one capsule.
I take zinc and vitamin C and vitamin E. Vitamin E. So, like we take those vitamins every day. So is that better than going to the AREDS 2?
No, I would only take the AREDS 2. Yeah, because that also has lutein and zeaxanthin, and the dosage, it has to be a particular dose for it to work. Yep.
Hi. I've got, in my right eye, it's dry AMD. In my left eye, it's the wet AMD. And I had the needles several years ago. It's been years. And my ophthalmologists have died, so I really am not getting any help right now. And the other problem, and I've also got glaucoma, and I just heard in the other room, somebody told me that you can do surgery for glaucoma, which I never knew, so I'm going to have to find an ophthalmologist, which is, it's difficult. But, I wanted to ask you about the, my biggest problem that I'm running into, and I don't know whether you've ever run into this before, and I'm not sure what's causing it, is I can't read. Fortunately, I can listen to an audiobook on my cell phone, but I have a strong magnifying glass. I've got a 24-inch screen on my computer, and I practically still make the font large, and I still practically have to use a magnifying glass. What's causing that reading problem?
Well,
have you heard of that before?
Well, reading comes from your visual acuity, right? In order to see, reading is part of the many tasks that you accomplish in order to see, right? So when we look at the cinema, for example, when we're driving, we can look at the distance, that's our distance vision, and then we also have something called reading vision. All of that, though, in order for it to work, in order for you to be able to read, your macula has to work, your retina has to work, your nerve has to work, your lens has to work, like many components of your eye have to be all intact for you to be able to read. It sounds like you were getting injections and you abruptly had to stop getting injections if you lost your doctor. Oh, okay. Well, either way.
The ophthalmologist that I had just died a few months ago. So.
Okay, I'm sorry to hear that. I do recommend getting back in to see your eye care provider. Start with an optometrist, and you can definitely get in to see a retina specialist. But injections, patients who used to get injections should not stop getting injections unless if the vision's profoundly lost. So, it's possible something is active and, maybe you need some sort of treatment. But also reading can be affected if you have advanced macular degeneration. Sometimes we're at a stage that's irreversible, and that's why your reading vision's gone.
Would that ever come back if I got more injections?
It really depends what stage it's at. It depends on your imaging, the stage of the wet AMD. Just by hearing the story, I can't tell you. You would have to be evaluated. Yeah.
And I just wanted to sort of add on to that, is that there, I'm not too sure, again, if it will work for your specific vision, but there might be different tools or resources that are available if you go to a low vision specialist. So either through something like Vision Loss Rehab Canada. Okay. And there's a low vision optometrist here today at a Jurassic who's got a booth. So it's possible. I obviously can't guarantee, but they're possible. There are other things you can do that might be able to help a bit.
I've been there, and they made these special glasses, and it hasn't helped me at all.
Yes, please
Thank
go
you. I have a two-part question. One is when you get an opportunity, can we talk about the future? Are there any gene therapy down the road for us? That's question number one. And the second question is that does red light help with macular degeneration? There's a lot of writing now and some research being done. So what's your opinion on that? Thank you.
Great questions. So the first question you asked was about gene therapy for macular degeneration. So yes, that is something that is in the pipeline. There are current clinical trials that many of us are involved in across Canada and the US for a select number of patients. It's a surgery that we do where you go in the operating room and you inject a gene that expresses anti-VEGF. So the drug that you're getting in your eye basically would be expressed in the form of a gene in your eye, so that would make you not have to go back for your injections as often, or maybe never. But it's not been approved yet, just because of its safety profile. It hasn't been established as a safe treatment yet. But I think in the next 5 to 10 years, it will probably be offered to about 10% of our patients. I think that will be. I mean, maybe sooner. I don't know. And then you asked about red light therapy. So that's what I mentioned earlier about light therapy potentially being an option for patients with dry AMD. So any stage of dry AMD, studies from the US and Europe on this device that comes from a company called Lumera. It's called photobiomodulation is the name of the treatment. Photobiomodulation is actually very exciting. They have shown that there is regression or reversal of disease to some extent. But it's in phase 2 study, so it hasn't been approved by the FDA yet, and it hasn't come to Canada yet. And when it does come to Canada, we don't know whether it will be covered by our OHIP coverage yet or not, but that's definitely something. If it does come to Canada, I think our center is probably going to be exploring that quite a bit. We're excited about it. So red light is just part of the 3 spectrums of wavelengths they're looking at. It's red light, blue light, and another type of visible light therapy, but it has to be a certain treatment algorithm. Yeah.
Could you just speak a little slower, please? These age-related ears aren't so good.
I apologize. Yes, I will speak slower.
I want to know, why do I have AMD? I understood it was congenital, and that it was, I thought I got a gene and that's it. But in the previous session, he said there were multiple genes. And so I'm looking to generations to come.
Yeah. Great question. Is that your only question? Okay. So AMD is multifactorial. There are multiple risk factors. Genes are only one part of the equation. So yes, some patients just have a very strong genetic component. There's a family history that goes around, and that there's nothing you can do about, unfortunately, right? You get your genes from your family, you pass it down. At the moment, and gene therapy is not currently, genetic testing is not currently recommended for macular degeneration, just because there's nothing we can really do about it. Even if you have the gene, nothing is done when we find out you have the genes. So, but that's just one component of it. There's other things. So being Caucasian is a risk factor. Having blue eyes is another risk factor. Blonde hair. So these are all factors that mean you have less pigment in your eye, and so you are more at risk for the effects of the UV light, basically. And so sun exposure, therefore, is another risk factor. So patients who don't wear sunglasses, for example. Smoking is a strong risk factor. History of smoking or secondhand, smoke exposure, as well as a diet that's not rich in leafy green vegetables. So patients who eat a lot of spinach, kale, or salmon in their diet have a lower risk. And lastly, it's your body mass index. So they found that the waist to hip ratio has also an effect on AMD. So patients who are thinner have a lower risk. Yeah.
I'm just going to quickly follow up on the question about the genes and genetics. So two things. If somebody has a sort of genetic predisposition to age-related macular degeneration, is it caused by a single gene, or is it sort of many, many genes? And the second question is, could you speak a little bit to, I guess, genetic macular degeneration, which I guess would be more of a, say, Stargardt's or something else, which is a genetic disease, but also causes macular degeneration?
Yes, thank you. So there are multiple genes for macular degeneration. So I would reserve the word degeneration, even though that sounds kind of bad because it's almost like a demeaning word, but let's just call it AMD. I would reserve the word AMD only for AMD itself, not for those genetic conditions. AMD has multiple genes that we know of. 2 of them have very strong correlation with AMD development, and then there's like 10 to 20 other genes that have some degree of effect. So it's a multifactorial thing. Some people have 2 genes, some people only have 1, and they still develop it, so everyone's different. And that's to answer your question about the genes for AMD. And then we have macular dystrophies and hereditary macular degenerative conditions that I wouldn't call macular degeneration. I would just call that a genetic dystrophy, for example. So there's Stargardt's disease, as you said, retinitis pigmentosa, cone-rod dystrophy. Those are things that show up earlier in life, usually in your adolescence, or childhood, and sometimes even in your early 30s and 40s. But AMD, often the average age is 70 to 75. Yeah. Does that answer the question?
I just have a few questions back here. I think you've just answered my question on genetic testing. Something that's confused me, people always talk about dry turning wet, but I believe that when we get the wet, we still have the dry, right? Is that correct?
That's right.
Okay, so that will still progress, even though we're getting injections for the wet, our dry will still progress?
Not necessarily.
But it can?
But it could, but it doesn't necessarily progress.
Okay.
Yeah. So to explain that, dry AMD is basically you have these deposits, these yellow deposits in the back of your eye. They grow in size, and that's how the disease progresses until you get atrophy. Not everyone will have atrophy, right? Atrophy I talked about a little bit, and that's still dry. There's no treatment for it. And then on top of that, or with or without it, you may develop wet AMD. Wet AMD just means you grow these vessels in the back of your eye. These vessels are anomalous. They bleed, they leak, they're fragile, and they lead to irreversible vision loss unless if you get injections in a timely fashion. The injection is an antibody that makes the vessels go away. And then the antibody wears off after 4 to 6 weeks, and then the vessels come back, and then you need more injections. And that's why you can't stop getting the injections. Yeah, if that explains. Right.
I just wanted to ask about myopia degeneration. Is that one of the ones that you're talking about? Or is
Yes.
it treated any differently? Is there anything different that one should know?
Yes, I do see a lot of patients with myopic macular degeneration. So that's a totally different diagnosis. It's a lot more common in Asia because, as you may know, patients in Asia are a lot more nearsighted or myopic, right, than in North America. But nevertheless, a lot of us are now starting to, all of us wear glasses. It's just myopia is becoming a lot more prevalent. Myopia means nearsightedness. When your eyeball is a little bit larger, you need glasses since childhood, for example. And, unfortunately, some of us develop advanced myopia to the point where we develop these blood vessels in the back of our eye, very much the same as wet AMD. So the pathophysiology it looks the same. You have abnormal vessels that grow, they bleed, and you need injections. That's called myopic macular degeneration. The good news, though, is that patients with myopic macular degeneration respond really well to injections, and they don't need injections often for life. Some surgeons only, like some of us only inject once, and then we follow, or we do 3 injections, and we stop, and we follow. Very rarely someone would need injections forever. That's very, very rare. I have a lot of patients with myopic macular degeneration. Usually they get 3 injections, and then I just see them every 3 to 4 months.
Oh, yeah, I have a quick question. Genetically, for instance, I got mine. My mother was blind when she died, but she had 3 brothers, and none of them were blind, and they were also in their 80s. So does it go from female to male, or does it stay with female to female? Because I have 2 sons who are in their 60s, and I worry about them. But considering I got it just from my mother, and her brothers didn't have it, I keep thinking that it goes from male to male or female to female, or does it cross male to female and vice versa?
That's a good question. It's not known to have a gender preference. The gene is an autosomal gene, so it's not a sex gene. And so there's no gender or sex preference for AMD. It's just probably luck, at least as far as we know today. There's many things we don't know, right? So maybe it is possible that in your particular family there is a sex-related gene to AMD, but that's not something that is yet known. Yeah.
I'd like to ask a question not related to AMD, but a different eye condition, and that is double vision. And it is occurring to me occasionally after cataract surgery, although my ophthalmologist said having 2 different lenses put in my eyes had nothing to do with it. And I don't understand why double vision can happen occasionally. Ophthalmologist said, just put your hand over one eye and it'll clear up. And it does in 20 seconds or so, but I was driving recently and it happened on the highway. So I quickly got off the highway and I went to emergency. And then when I had an appointment with a neuro-ophthalmologist, he examined it and said, well, one eye access is lower than the other and prism glasses will help. But is this age-related? Why does it happen, and why just occasionally?
So that's a good question. Double vision or diplopia, that's a whole topic of its own. I can talk about that for 10 hours. It's, everyone's different, true double vision, fake, and then there's pseudo double vision. But sounds like you've already been seeing a subspecialist for this. I don't know your particular condition, but common things being common, if everything else has been ruled out, like it could be due to a stroke, right? They have to rule that out. Diabetics often have some palsies of a nerve, for example, that goes away. Sometimes, very rarely, it could be a tumor, So those things need to be ruled out. And then the most common thing is that you might have had some sort of imbalance between the muscles of the eye, but when you were younger, not to say you're old, but usually under 40, most of us are able to balance things, and we have enough eye muscle power to be able to compensate for the eyes not being aligned. And as we get older, as we get tired or drunk even, we lose that ability and our eyes go out or they go wonky, right? And that's just the decompensation of what's called the decompensated phoria. So then you need prism glasses to bring the eyes together. But I mean, again, like you might not have a decompensated phoria, you might have something else. I would just probably check with your neuro-ophthalmologist. Yeah.
Just have a question over here.
Yeah.
Hi.
Hi.
I have wet macular degeneration in my left eye, and I've been taking shots for quite some time. Recently, my doctor said I'm in a very low percentage of people where I don't have to take the shots anymore. I don't know if, would this go on for a long time, or that I wouldn't have to take shots? I go in every 6 months to be tested, but he said it seems to be fine, and we'll keep an eye on it.
That's great. There is 15 to 30% of wet AMD patients probably don't need injections forever. There have been studies on that. We just don't know which patient that is. Sometimes in the past, like many, many years ago, as far as I know, we used to stop treating patients who were stable after a few months, and we said, great, you're cured, you're done. But now we know that's not really, there's no cure for wet AMD. You have to keep injecting patients because sooner or later, usually some of them will have a bleed. Like you might be fine for 9 months and then have a bleed and lose vision. There are several factors that go into deciding which patient can stop treatment. In my practice, I would only stop treatment for patients who have advanced vision loss, for example, or who have certain other diagnoses that might be misdiagnosed as AMD. But that's just my practice. I would specifically ask that. I think you might be in a rare situation. I would just ask your particular specialist about why they stopped treating you. But that sounds great. If you've been stable for a long time, that's awesome. I'm glad to hear.
You've mentioned smoking several times, and I'm wondering if you mean smoking in the past or current smoking. I've got a guilt complex here. I was a very heavy smoker for 33 years, but I quit 40 years ago. Have I?
Yeah, unlike lungs that actually reverse and the disease goes away from your lungs when you stop smoking, unfortunately a history of smoking, even though it was 30 years ago, it's still a risk factor. But there's nothing you can do about that. The good news is you stopped smoking a long time ago. But that's probably one of your possible risk factors. Is it definitely the smoking that caused it? No. You might, even if you didn't smoke, you might have still developed macular, right? So I wouldn't focus too much on the past. Yeah. But if you do have, children, grandchildren who do smoke cigarettes, definitely advise them to stop.
You said something earlier about AMD spreading. Did you mean it can spread from one eye to the other?
I didn't talk about spreading. Are you talking about progression of disease?
Possibly. I might have misunderstood. But is it possible to give one eye AMD to the other?
So one eye doesn't spread to the other because it's not an infection per se. It's a genetic condition. Often genetic conditions show up in both eyes. Just like when you get a freckle on one side of your body, chances are you have 10 other freckles the rest of your body. It's the same thing, macular degeneration. If you have it in one eye, usually you have some degree of it in the other eye. Most patients have asymmetrical involvement. Like you might have advanced disease in one eye and early disease in the other eye. And then I would say 30% of my practice, they get injections in both eyes. So, it's a matter of time, luck, and genetics.
What are the symptoms of dry macular degeneration?
Yeah, often no symptoms. Often dry macular degeneration doesn't affect your vision until it's advanced. And so that's why you should have regular eye exams with your optometrist, would be the first point of contact every year. And they can diagnose that based on clinical findings as well as imaging findings. And that's how it's usually diagnosed. Usually patients have no symptoms.
No symptoms. You can see just normally, right?
It depends, but usually yes, at the beginning, yeah.
And then it goes into the wet aspect.
Not in everyone, but that's why you should diagnose or get diagnosed so that you can be monitored. There's a percentage of patients who then progress. Not everybody gets wet AMD.
Do you laser people with dry?
There's no approved laser therapies currently for dry AMD. I do a lot of laser in my practice, but not for AMD. I'm just going to pass the microphone to Larissa.
I just had a follow-up question. I know there was a question earlier about treatments for dry AMD, and I know we get a lot of questions because there's a couple of treatments that are available in the States, not available here. I think there's Iveric Bio has one, and then the other one that you mentioned. So I was just wondering, they are being used in the States. We know people who go down and get them. And so how do you talk to your patients about that when they come to you and suggest that should I go down to the States? If they have the funds, of course, too.
I think that's a great question. So the therapies that are available and approved in terms of injection for dry AMD, that's only for advanced dry AMD for patients who have atrophy. Okay, so for early, intermediate to severe dry AMD, no treatment. It's only if you have atrophy, and only atrophy of a certain size and a certain type of visual acuity, that is a candidate for those injections. And like someone else asked this question earlier, those injections, they do have a safety concern. You know, there have been several adverse events that have been reported to the American Society of Retina Specialists REST Committee, which is the, you know, Adverse Events Committee, in terms of sudden vision loss and irreversible like necrosis. And because of that, I would probably tell patients to be very cautious, especially if that's the only eye they have, if their other eyes already suffered from you know, massive vision loss. And then the other thing is the margin of improvement with those injections. So those injections don't improve your vision. The take-home message is that you need to get these injections once a month in your eye forever to minimize your risk of progression of atrophy. And some people have, you know, a success rate of 1%. So if you're willing to go down to the US and get an injection in your eye once a month forever, for a possibility of maybe preventing it from getting a little bit worse, that is a decision that should be made on a personal basis. You know, I personally would probably discourage my patients from pursuing that. I would say the effect that it has is so marginal that I don't think it's going to make a big difference. With rare exceptions, so patients who have advanced atrophy or dry AMD in both eyes, and they are relying on their one good eye that's also legally blind, for example, and the other eye is completely gone, then they have a lot to lose if the good eye also gets worse. And so for those patients, it might be beneficial because that's kind of like the last straw. You want to do everything you can to save that little bit of vision that you have. And so for those patients, it's probably a good idea, but that's a very small population of our patients. I don't mean to be so negative. I mean, there may be a new drug that gets approved in Canada and the US in the future, but the ones that are currently approved, unfortunately, I don't think necessarily they're going to make a huge difference. And that's why they're not approved yet here.
Okay, I envy the guy who's not going to have injections in future. Do we know why some people don't respond as well as others? I mean, when I was on the ILEA, I was down at every 3 weeks, and we were talking about going to every 2. I've heard the word pathway mentioned, and also maybe blood pressure.
No, not your blood pressure. So why do some people with AMD respond better than others to injections? Yeah, I mean, that's kind of the age-old question. You know, if we knew the answer to that, we could provide personalized medicine, right? So person X would get this.
It was my retina specialist who mentioned blood pressure when I asked him the question.
You might have a different condition. I mean, you.
AMD.
And on top of that, do you have something else? Like, you know, no. Well, I would clarify that. There's also eye pressure. They might be talking about your eye pressure potentially.
No, he was talking about blood pressure.
No, not as far as I know. Blood pressure can cause other problems that also require injections.
Right.
Like a stroke in the eye, basically, or vein blockage. But now, why do some people respond better than others? It's thought that some of us produce certain cytokines or molecules when we have wet AMD to more degree than others. So there's something called VEGF, vascular endothelial growth factor. But there's also many other proteins, such as placental growth factor or Ang2, which is angiopoietin, which is another cytokine that's released in the retinal space when you have wet AMD. So, you know, Sarah might have more VEGF than PGLF, for example, and so they will respond really well to anti-VEGF. But, you know, Jane might have higher levels of Ang2 than VEGF, so VEGF therapy won't help them. They will need another drug that blocks the other molecule. But right now, we don't have any way of measuring that from patient X to patient Y to say which one will respond better.
I just have a question over here, this lady. Liz, you had a question?
Sorry, it wasn't a question, but I've read quite a bit, and I know in the States, they often give a dark adaptation test to see if you know, to keep track of whether or not you could be getting geographic atrophy. And in actual fact, I did notice early on that when I went into a movie theater, it was taking me longer to find an empty seat, you know, than otherwise. And that was a little embarrassing the first time around, I'll tell you. There was somebody already in it. And it's an optometrist in the States that does it on a regular basis, and I'm not sure why they don't offer it in Canada, because it is considered a first symptom that something could be going on. And you can get it when you go from particularly from a very bright into a darker area. It just takes your eyes longer to adjust, and apparently that's because the cones don't adjust as quickly as the rods do. And so that can be a first clue. I just wish that they would let people know a little bit more about that one up here, because it's non-invasive and it's a cheap test that can be given.
That's a good point. So first of all, that test is not recommended by medical societies. So the American Retina Society and the Canadian Retina Society don't recommend dark adaptation testing. So as you mentioned, it's not an MD who's offering it, it's an optometrist who's offering it. And it's not something that's in our literature or guidelines based on, and so the question is why? You are correct, that is one of the early signs, but that's because we have better tests than dark adaptation that can diagnose you earlier, and they're a lot easier, faster, and cheaper to do, including something called OCT, which is optical coherence tomography, totally non-invasive, takes 1 second to do, and you can start by getting that test at your optometrist, for example. Dark adaptation testing is probably just an add-on test.
No, it's not.
It's yeah.
Excuse me, not in this particular optometrist who's been doing it for about 10 years. And it was also recommended by a retinal specialist who has done clinical trials himself. And he was strongly recommending that people have this test because it is non-invasive and it is a very reasonable one. And it would be done at the optometrist level. You're absolutely correct about that. But it was one of the well-known optometrists in the States that has been doing it for about 10 years.
Right, so 1 or 2 doctors, they don't comprise, we have hundreds of thousands of doctors that get together and put together guidelines, and they don't recommend doing that test. But, by all means, it's non-invasive and it's not that expensive, so there's no harm to doing it.
Except if it's not offered, you can't have it done. I'm just curious, the fact
it's offered,
that
it's available in Canada. It is. I send my patients for dark adaptation testing, for sure.
Well, that's really interesting because I don't mean to argue with her about it, but I was asking an optometrist about it, and the reason they gave, you're quite correct, they said, no, we don't recommend it, nor will I ever, because does it prevent it? No. Does it cure it? No. But for me, it's an early warning that you better start paying attention to your eyes, because a lot of people tend not to go to optometrists on a regular basis, and it can be so slow in developing that you're not even aware that it's happening. It's just, I guess for me, it's one more clue earlier on, time to start thinking about your eyes. I have advanced in both eyes, both kinds, and it was just thanks to a chance remark from my mother's cousin that she had it, my mother had it, and I could get it too. So I also did have the genetic testing that it didn't send me into a deep funk for the rest of my life from age 40, but it did remind me, when you get older, start paying attention. That's all I'm saying for those who are interested in trying to keep on top, because when you get it, it's especially advanced, it's horrendous.
Absolutely, yeah. It's not recommended, so I don't recommend, asking for those tests. But I think that's a good point, though, that it makes you feel worried. Yeah, go ahead.
I think we're actually at time. I would say I'm going to end off with the note of
thanks for the break.
Yes, make sure you get your eyes checked regularly. I think that's a good take-home message. So make sure you're going to your optometrist, your ophthalmologist, your retinal specialist, whoever is your primary eye care provider. Regularly to make sure that you're catching any changes as early as possible. So this is unfortunately the end of the session. I feel like we could have kept on going, but it's time to wrap up because otherwise Morgan will get mad at me if I don't get you out of here in time. So if there were questions that you had that weren't answered, you can contact our health information line at healthinfo@fightingblindness.ca. There's going to be another break now for 15 minutes until 4:15. So please go outside, check out our community fair, grab a drink, and then also fill out your bingo card if anybody is filling out their community fair bingo. And then at 4:15, we're going to be back in the main room for our lived experience panel. So I want to thank Dr. Arjmand once again for joining us.